it's not about giving up. And we don't want people to give up. And people always look at me like, what do you mean you don't want them to give up? I thought that's what hospice was. No, it's not about giving up. It's about doing everything to fulfill somebody's wishes, and that we're never going to give up hope. You hear that a lot too. And the myth about giving up hope, hope to a patient might be something as simple as, I hope you're not going to leave me alone. Or I hope you're not going to let me die in pain. So, you know, those are the type of myths that we encounter when it comes to hospice. And when people fully understand what the hospice benefit is, that's when you see them go, I never knew that existed. That's the best thing that could ever have happened to my loved one.
The myth that still exists that hospice is a building, a freestanding building that you go live in, and that mom and dad or grandma will never return back home, is a myth that really, I believe, holds patients and families back from making the decision on choosing hospice. Hospice is a service that is provided to the patient and family in their home. And I know that it's, you know, we take that very seriously, because we know that this patient and family is allowing us to come into their most private, you know, home, their surroundings, their family, and they're inviting us in. And so we take that care very, very seriously. And so I've seen where, you know, really together, it improves their quality of life. We're focusing on their symptoms. We're ensuring that they're comfortable. As symptoms arise, we're being proactive and treating those symptoms so that they don't end up in a hospital. And therefore, their quality of life gets better.
They should be looking at it from the standpoint of hospice is a full range, is a full service that that helps them to deal with whatever they're going through at a very difficult period in their life. That the Medicare hospice benefit was designed to reach all aspects of a patient, to give them choices. Choices about where they want their care delivered, how they want their care delivered, and what their goals are in terms of how they want to feel psychosocially, clinically, meaning, you know, the type of care and hands-on care they would like to give, and to be able to have information about what they're feeling, how this is affecting the family, the psychosocial aspect of it. So all of those aspects to deliver the best care possible for somebody at the end of life. Because we always say, you come kicking and screaming in this world at birth, shouldn't you have a good death?
I feel that it's important for everyone in our community, regardless of what your age is, to be informed with as much information as possible, so that when the time comes to make an informed decision as to which way do I go, because we have the right to choose. We have the right to choose, I want everything done, I want acute care till the very end, and we have the right to choose and also say, hey, you know what, I want to be at home. I don't want to go into a hospital anymore. I want to die in my bed, surrounded by my family and my familiar surroundings. And we have that right, and we have that right to talk to our physicians and to talk to the medical community and say, hey, wait a minute, I heard about hospice, and I heard I can learn more about that. Would my loved one be a candidate for this type of service? And I'd like to become informed of such if they are. Because I think it really should be, you know, I find being in this field that a lot of options are given to patients and families, but hospice isn't one of those, because nobody wants to refer back to that word of hospice, because again, it brings us back to that myth, well, my doctor just talked to me about hospice, he's given up, that means my mom is no longer, you know, she's not going to get better anymore. And that's not true, and I think it's an injustice to themselves, because they're holding back from perhaps just at least learning about information that can really be helpful.
Well, what we say in Vitas is that the patient and the family are always at the center of our care. And the center of care meaning that this is the one time in medical care that they get to make the decisions. They're in the driver's seat. And it is our job on the interdisciplinary team to help them through whatever is going on in their process. So in taking care of the whole patient, The interdisciplinary team exists with the team manager who directs that care, but also the team physician who does make house calls, the social worker who can access community resources, say if a patient and family needs Meals on Wheels because they've been dealing with a terminal illness, or it could be the chaplain who are non-denominational. And this is the heart of what hospice is reaching out to that spirituality. Spirituality is not religiously based, but it could be the changes that happen to a person, and we call it transcendence, that happen when they're going on their journey. So, and the clinical aspect. So, for example, if a patient's in a lot of pain, and that would be our number one goal when a patient first comes to us, is to get the symptoms under control. So if we can get those symptoms under control, we know a patient will be responding to their family much more comfortably, not in anger, not in grimacing, but in a relaxed manner, so that the whole experience for the family then becomes one of comfort as well. And then we have our home health aides that respond for activities of daily living. So it's the whole patient, the whole concept, from the spirituality piece to everything, and understanding what's going on.
When a person asks me, what should I look for in a hospice agency? What should I really define before we make this step to receive hospice services? I usually recommend that they start with an informational visit from a representative from the hospice. I recommend that they ask about night call manager systems and how long it takes if there's a crisis in the middle of the night for a nurse to come. I also recommend that they ask about the psychosocial team. Will there be a spiritual care counselor? Will there be a volunteer? Will the social worker come out, and with what frequency, to help with non-medical and non-nursing aspects of the individual's care? As a physician, I highly recommend picking a hospice agency at which the physician, the hospice physician, can come out to the home and be a help. That may be to review medications. That may be for a specific symptom. It also may be to reassure the family that they're being taken care of by a caring doctor on the hospice side, in addition to their community doctor. That's a feeling that sometimes can only be given by coming to the bedside and meeting them. And I think it's a really important thing to preserve within the hospice care we deliver. I think one of the biggest misconceptions about hospice care is that we're giving up on people. We're not giving up. We're not taking away hope. We're refocusing their goals on how they want their time to be with their family and with their loved ones. That's giving hope, and that's enriching life as much as possible. The timing for hospice is when a person who has a shortened life expectancy that's less than 6 months chooses to focus solely on quality of life, and for the most part, spending time at home with their family. They're choosing to make the hospital and the medical system less of their day-to-day life. They still get medical, nursing care, psychosocial care, spiritual care, but they're making a very informed decision to focus on quality. What we try to do in hospice is align hospice's philosophy and treatment goals with the patient's clinical condition and their goals, so that if staying at home is important, if quality of life is important, if acknowledging that their time is short, that may be measured in months, that hospice and the hospice philosophy will very likely be able to serve them well. Our aim in hospice care is to make the person living with an illness that is terminal feel like a whole person, feel like a worthwhile person, feel like a person who still has something to contribute to the world. And that trust from which that springs begins with compassion, making them feel like, from my heart, from my mind, from my team's heart and mind, they're cared for wholly. Hospice care at its core is still a philosophy, but hospice in its practice has evolved tremendously in the last 30 years, and excellence is keeping those two traditions alive and well. Hospice care is a subspecialty practice of that tradition and that system of care that ensures it continuously, today, yesterday, and into the future. The part of the Beata Way that's most important to me is that all of our employees, myself included, show love for their patients. And it's not something that we're told to do. It's certainly something we're encouraged to do, but that it's so clearly stated that that's part of our work, that you show love in how you care for people. Yes, you bring your excellence, your knowledge, your reliability, you show up, your compassion, but that we speak about showing love and we do it in practice on a daily basis. I think the thing that makes Beata most special, what I'm most proud of, what differentiates it for me from any other previous employer, is that it's written down that we show love for our patients. When you know that not only you, but your colleagues all over the country are also showing love in their work, it builds strength and it builds confidence to do it again and again and again, and to take pride in it, to get better at it, and to feel that it's self-renewing, that you can show love, maintain your professional expertise, but do it for many years to come. We may have taken care of hundreds or thousands of other patients, but for this one patient, this is their one time to go through this part of their life. And the Beata employee, backed by the Beata Way, backed by a whole team that aspires and does achieve excellence, compassion, and reliability in care, is a very, very special gift which Beata enables us to give over and over reliably. Mark Beata is our president, our founder. There would be no Beata without Mark Beata. Mark is an incredibly special and gifted human being because the amount of heart that he puts into the planning of this company and to the amount of organization and skill he brings to supporting all of us in this very tender work. The hospice practice within Beata is a specialty practice. Those of us who do hospice, whether it's in the office or in the field, we do hospice. We take care of hospice patients. As a physician with specialty training and certification in hospice and palliative medicine, it's very important to me that every member of the team, from the volunteer who's been trained in hospice to the social worker, the nurse, the spiritual care counselor, our administrators and office staff, that they're all focused on hospice, that it's an expertise, and that it's a specialty service during people's most tender and vulnerable moments. The timing for hospice is when a person who has a shortened life expectancy that's less than 6 months chooses to focus solely on quality of life and, for the most part, spending time at home with their family. They're choosing to make the hospital and the medical system less of their day-to-day life. They still get medical, nursing care, psychosocial care, spiritual care, but they're making a very informed decision to focus on quality. A person is eligible for hospice when 2 physicians certify that they have 6 months or less to live. This can include a wide variety of diagnoses: cancer, dementia that is very advanced and is showing signs of complications and terminal decline, congestive heart failure that is very advanced and for which people are very symptomatic, end-stage respiratory diseases that might include emphysema or chronic obstructive pulmonary disease are also included. A person who wants to enroll in hospice will begin by having a discussion with their doctor. I think what's most special about providing hospice care from within Beata is that Beata has an almost 40-year history of taking care of people in their homes with compassion, with excellence, with reliability. Hospice care is a subspecialty practice of that tradition and that system of care that ensures it continuously, today, yesterday, and into the future.
It is very important to have a team approach at end-of-life care because not just one specialty can take care of the patient. A patient who's terminally ill and is diagnosed to be dying have multiple needs, not just physical pain, but we see the total suffering, in a total paradigm wherein we treat their physical pain, emotional pain, spiritual pain, as well as social pain. So team approach of different professionals really can best support the patient.
Within that team is the physician, a nurse manager, a case manager or the nurse who's at bedside with the patient, a chaplain, and a social worker. And we work together as a team, meeting weekly to discuss our patients and to help identify any problems that may be present.
When a person comes on hospice, we try to encourage their attending physician, the physician who has known them the best, to continue to follow them, to monitor them, to be engaged in their care, to work cooperatively with this interdisciplinary team. The importance of the physician the physician who knows the individual the best, continuing to follow his or her patient is extraordinarily important.
The team can focus the appropriate resources for the patient quickly, seamlessly, and in a way that the patient is in control, patient-centered care. For me, hospice is really the only area where that takes place.
Hospice care is paid for by nearly all insurances. The majority of patients that we have under care are Medicare beneficiaries, and the Medicare hospice benefit reimburses every hospice on a daily basis for every day the patient is under care, and that payment takes care of all services. Therefore, any medical intervention that is related to the patient's terminal illness, it is entirely paid for by CMS. Many commercial insurances, Medicaid, Medi-Cal now, have a hospice benefit, and we accept that as payment in full for the care of the patient. We also pride ourselves on the fact that if the patient has no source of funding, we will accept them and give them exactly the same care that we would to a Medicare beneficiary or a commercial patient.
So let me throw some things at you and see if you agree with me. No one should live in pain. No one should live in fear. No one should die feeling alone. Everyone deserves to be a partner in his or her care, not just be a patient. Children deserve to have their grief honored and their lives celebrated. We need to change the way we face death and dying. You probably agreed with that. Well, that's the philosophy of the San Diego Hospice. And to talk about how we palliate people at the end of their life, how we make that a special moment, how we maintain their dignity, we have with us an expert, Dr. Gary Buchholz. Welcome.
Thank you.
Dr. Buchholz is the Clinical Medical Director of the Institute for Palliative Medicine at the San Diego Hospice. It's a mouthful.
Yes.
I cut that piece out that I read to open because I was so touched by that, those principles that were elucidated on the website. of what you believe in. And it's very powerful to hear those because I think everybody believes in that.
Absolutely. I've never heard anyone disagree. And those are really our core beliefs, and they tie very closely to palliative care and hospice care.
Well, we've said that now a couple of times: palliation, palliative care, palliative medicine, hospice care. We're going to have to start explaining what those things are. So let's start with palliative care. What is palliative care?
Sure. Palliative care is a type of medical care that is geared towards treating symptoms like pain and other symptoms like nausea or shortness of breath. And it's for people no matter the diagnosis or the age of the patient. It's often associated with geriatrics or cancer care, but the opposite extreme would be a child who has an illness that has maybe a non-cancer illness that has associated with it severe suffering, whether that's physical, emotional, or spiritual. And palliative care, I get the luxury of working with a team to address that. And really the ultimate goal is on improving quality of life. And that type of care, palliative care, occurs side by side with traditional medical care that is looking to prolong life or potentially to cure illness or a disease.
So palliative care is not only with end of life.
Absolutely. Palliative care is at the full spectrum of disease management. It should start at the very beginning of a diagnosis.
Now, when I was in med school and through that, I always knew about pain management services. This is more than that.
Yes, it's very much more than that. And we work closely with pain management services. Pain management services are usually doctors who are trained in anesthesia, who are trained to do certain procedures to help with pain management. And so we partner with them in appropriate times. But palliative care is about the whole person and treating that whole person. I know you had a guest on recently who talked about the mind-body connection and how important that is. And that's part of palliative care as well. There's emotional and spiritual suffering that comes with a physical illness.
It seems to me that alleviating suffering is what you're doing, and that, to my knowledge, when you do that, people actually sometimes heal better and the disease goes better. The old studies of people who watch comedy movies, you know, to make it a simple point, the positive attitude that you can get by alleviating suffering actually helps the process of treating the patient, not just makes them feel better.
Yes, that's very true. In fact, oftentimes people ask me, isn't your job sad? And I respond by saying no, and certainly parts of it are sad because sad things are happening to our patients sometimes. But my job is very rewarding because if someone's suffering from severe pain, sometimes within a day or less I can make that very different working with a team of people. And that feels so good. Someone who was actually focused on their illness is suddenly focused on feeling good and enjoying life, and that feels really good for me.
I think my son would say you'd become that person's NBF, you know? I mean, you took away the pain.
Yes.
Just a simple example. I know from a pain standpoint, I had really bad back pain at one point, thought I was gonna have surgery. Somebody took away my pain and it allowed me to do physical therapy and other things to get back to functioning. I felt better just functioning. I felt better getting up each day, and my attitude changed. And that's just a tiny little sliver of it. I would think you really do become people's best friend.
Yes, yeah. And often it feels like I'm doing something very simple. Our chief medical director, Dr. Laurel Herbst, says don't undervalue what you do, but some of the things we do are very simple, and it's just so fun to see the night and day change sometimes that our patients experience.
Can you give me an example of a simple intervention that made a big difference?
Well, where she says don't undervalue what you know, for example, coming to San Diego Hospice and the Institute for Palliative Medicine, I learned how to manage pain medications, and for me it seems very simple to do that. So making a little change in pain medications can sometimes create a drastic change for the patient and sometimes for their family, their caregivers as well. And sometimes it doesn't take very long to achieve that. And it seems very simple to me.
You sound like the classic expert who thinks what they do isn't hard, but everybody else thinks it's a huge deal.
Yes.
Well, I think that's great. So I think we're getting a sense of what palliative care and palliative medicine is. Why is that linked into hospice then?
Yeah, so they often go hand in hand, and some people use them interchangeably, and that's not quite right because hospice is palliative care, but it's really enhanced palliative care for someone who has a life-limiting or life-threatening illness. And it's enhanced palliative care, and people think that it's often a place that you go when you're ready to die, and that's not right. It's an extra level of service, and it most of the time happens where people want to be. They want to be in their home, surrounded by their loved ones, and they want to stop that cycle of bouncing back and forth into the hospital. No matter how great your hospital is, it's not a fun place to be as a patient. So that with good, this extra layer of services that frequently occurs at home, for the far majority of our patients, it often can stop that cycle. It doesn't prevent going to the hospital if that's needed, but it can often stop that bouncing back and forth.
So I'm thinking about someone with a terminal illness who is likely going to die in the relatively near future and has a family and has a life, and everyone is affected by that. That's where hospice comes in?
Yes, absolutely. That's exactly where hospice comes in. However, people are usually referred to hospice late because it's a hard conversation for doctors to have with their patients. And it's a hard shift for patients to sometimes make because, again, they think that I have to be prepared to die, and I'm not prepared to do that yet. And what people don't know is that it doesn't prevent life-prolonging therapies, and it is an extra layer of service. You don't have to give up your healthcare team, your doctor. It's essentially just adding that extra layer, which is very helpful at getting people to enjoy life again.
Yeah, I'm an ophthalmologist, and in my world, if people go blind, it's failure. You feel like you failed. In the general medical world, if someone's dying, you feel like you're failing as a physician. And I can imagine that a physician the average general physician looking at their patient, the average oncologist who's trying to battle cancer, the average cardiovascular specialist trying to battle these diseases who want to go down fighting. I mean, we're the A students, you know, we're the people who want to win. They want to go down fighting. To look at someone and say, I don't think this is going to work, is almost tantamount to an admission of failure on the doctor's part. So how do you work with the general medical world to begin that process? Because that's the first step, it sounds like.
Absolutely. So we, the Institute for Palliative Medicine, is involved in first training because it's a hard thing to do, but there are skills you can learn to do it effectively. And no one wants to hurt their patients, and that's not what they're doing. They're conveying information, and it's a challenge to do that, but we can teach the skills to do it. So we're involved in training the medical students from UCSD. We're involved in training 10 of the essentially primary care specialties and HEMONC program through UCSD. We're involved in training all of the residency training programs here and how to do some of those things. So even if they don't go down the path of being a hospice and palliative medicine specialist, they have those skills to be able to do that effectively.
It touches every field of medicine.
Oh, yes, yeah.
You know, our patients die because people die. So every doctor needs to know this. I certainly never had this exposure in medical school, and it's exciting to think that doctors are getting some training in even just the sensitivity that's needed to broach these discussions.
Yes, and ultimately it's a part of changing that feeling of failure if your patient dies. It's not our goal for our patient to die, but ultimately, unless our patients outlive us, then our patients are going to die, and we need to be prepared for that, and our health system needs to be prepared for that.
Look how good you are, because I'm listening. You're not just alleviating the suffering of the patients and their families, you're alleviating some of the suffering of the doctors. You're good at what you do. I mean, to think about it that way, that's what the whole system needs you to sort of massage it a little bit to make sure that everybody gets handled appropriately.
Yes, and the system needs more of it. We talked about palliative care. The system needs more palliative care, and that's one of our missions of the Institute for Palliative Medicine is to transform healthcare by putting palliative care into existing healthcare systems. So that includes hospice, but it goes beyond that.
Let's talk a little bit about some of the nuts and bolts. You've alluded to this a couple of times. Hospice and palliative care is not a place, it's a state of mind and an approach to care. But there is a place also. So when do you end up at the place, the hospice, and when do you end up at home? Does the patient have the choice? And then I want to get into the process of what the patient choices are, what choices they don't have, et cetera.
Sure. Well, this is really one of the myths of hospice care, which is that all hospices are the same. And Medicare requires hospices to have some core services that have to be the same. But then some hospices go beyond that. And so this is where San Diego Hospice stands out in some areas. One area is that we have a couple of inpatient hospice units, so that they are hospital-like in that we can provide intensive therapies that you might consider normally performed in a hospital setting, but they have a much more home-like atmosphere. We only use those facilities when things aren't going well at home, typically where the patient and the family wants them to be. And so if things aren't going well at home, if we're not controlling a symptom well, then they may want to come into our inpatient unit for those therapies. They also have the option of going to their regular hospital if that's what they want. But towards the end of life, patients will often choose this specialized setting to focus on quality of life and their symptoms.
Do they have to use the doctors there? What happens to the doctors they may have known for 20 years?
Sure. In our inpatient setting, we have doctors who see the patient every day, and those doctors will stay in touch with their doctors. It's like going to the hospital and seeing a hospitalist, only this hospitalist has specialized training in palliative care. So that doesn't mean your doctor's not important or not part of it. Certainly there's contact there, and they're still an important part of your care.
Does the person involved who has the disease have to say, I'm no longer going to try and be treated? Do they have to give up the thought that maybe, just maybe, that last round of chemotherapy might work even though they have a terminal diagnosis? Maybe, just maybe, something might come up? Do they have to give that up?
They do not have to give that up. So another myth is that you have to have a do not resuscitate order signed to be eligible for hospice services, and that's simply not true. And another myth is that you have to give up those therapies, and that's not actually true, although that is where some hospices are different than others, and it's important to ask. So in San Diego County, there are 14 different hospices.
Wow.
Often people are surprised to hear that.
I am.
But it's important to ask, how are those hospices different? Some are for-profit, some are not-for-profit. And can I continue to receive these therapies that I think are important for me, that my doctor wants me to continue to have?
So they may have those options. You mentioned Medicare requires certain things. That implies Medicare pays for this. Does Medicare pay for hospice/palliative treatment, and does anyone else pay for it?
So yes and yes. Medicare pays for the far majority of hospice because most people who have a life-threatening illness are 65 or older in this country. And so Medicare has a benefit that they've created and some core things that go along with that to be considered a Medicare certified hospice. However, so then Medicaid or Medi-Cal in this state also has a hospice benefit. And then frequently, private insurers will also have a hospice benefit. And actually in California, we're very lucky because there's a law that says that all private insurers must provide a hospice benefit. There's a small number of individuals who don't fall into either of those categories and have financial savings that don't make them eligible for charity care, and those people self-pay, but that's a far minority. And then again, there's charity care.
Sure.
And last year, San Diego Hospice provided over $1 million in charity care. We don't turn away a patient regardless of their ability to pay. And so we can't do that without the huge donor support that we receive in addition to the Medicare and other insurers paying for services.
Doesn't that make you feel great when you wake up that you know that you can see everybody and anyone? I mean, that you can, your job is to take care of people.
It really does. It feels great.
Yeah, that's really cool. That Medicare puts rules on. Is there a time limit that someone can go into hospice? I mean, is there 6 months? And, dude, you're still alive. I mean, does that happen?
Yeah, so you mentioned 6 months, and so the prognosis needs to be estimated that it's likely 6 months or less if the illness runs its normal course. The problem with that is that on the whole, doctors are pretty bad at doing that. We tend to, for various reasons, overestimate prognosis, meaning we think that the patient's going to live much longer than they do. And some studies show that we do that by 3 to 5 times. So
it means they get to you late.
They get to us very late. Our median length of stay is about 3 weeks.
Wow.
So a lot of things have to happen in those 3 weeks to get our patients feeling good and to plan for what's going to happen if it looks like it's going to happen soon. But there's no limit on the hospice benefit. So if you believe your patient has a life-threatening illness and they could benefit from this extra layer of service, then it's time to think about referring or to contact your local hospice and ask, is this person eligible? And lean on your hospice to help figure out
whether or not
they're eligible for services.
That's got to be tough, as we talked about earlier, that in the middle of the battle, the doctor's thinking maybe we'll still pull out of this. If it goes well, maybe the patient recovers. If it doesn't, maybe he's got 3 to 6 months. It's a hard moment to start saying we should talk to hospice when you're trying to keep everybody going forward, but I think that we need to redefine how we think about this.
Yes, and will it change the plan of care to add hospice? To add that extra layer, will it actually change what we're doing? And frequently the answer is no.
Who are the other, doctors are on the team, who are the other people as part of the team that patients encounter?
Yeah, I'm glad you asked that question because it's really important in what I do. And so I'm lucky to get to work with nurses that most doctors work closely with, but I also work with social workers, counselors, spiritual counselors included in that, and then various other additional folks. So volunteers are part of our program, our hospice program, and then sometimes integrative therapies, complementary therapies like acupuncture. We have a close relationship with the Pacific College of Oriental Medicine, so massage therapists, aroma therapists. So I get to work and lean on all of those folks to help me provide the best care for the patient and their
creative.
families.
That's an extremely creative approach to this whole process. That you have the opportunity to open your eyes and spread your horizon is again, had to be very fulfilling for you.
Yeah, absolutely. It's fulfilling, it's rewarding, and when sad things are happening to a patient, I get to process that with the team members that I work with. And unfortunately, a lot of doctors don't have that opportunity, and we'd like to take those principles and put them into healthcare systems. Doctors often feel very isolated when in spite of the best medical care, sad things are happening to their patients.
When we lost my dad, I remember thinking, I really want this to go well. I want these memories not to be bitter memories or painful memories. I want to make sure my dad has put his things in order and that he's comfortable as he leaves. I was struggling to do that myself. I was a doctor and I really didn't have anywhere to turn or know how to deal with it. And supposedly trained in all that. This is not something people can do on their own so easily.
No, definitely not. And most people don't know that you're not alone, that these services are out there, and that they're different than what you think they are. You know, if you think it's just right before death or when everybody's ready for their loved one to die, that's not what it's about.
That's not what it's about. One thing that I came across that I wanted to just touch on that I was really impressed with was prenatal care for parents of a child that's going to be born with a significant problem or clearly not going to make it or have those issues. Didn't occur to me that hospice would be involved in that or palliative care would be involved.
Yeah, so as part of the children's program, Dr. Kim Bauer and Dr. Tanya Dansky oversee as well as the children's program, the perinatal program. So if a woman who's pregnant is told that it's likely that their baby is not going to survive or not survive long after birth, and they decide that they would like to continue that pregnancy and carry to term, then they can receive a team of people to help create a birth plan. As what is that going to look like? And maybe I'd like the opportunity to hold my baby, and so creating the birth plan and having team members, if you wish to have team members there to help support you in that birth plan, that's what the perinatal program offers.
You're changing what would normally be a terrible experience into maybe a moving spiritual one.
Absolutely, yes.
That's almost miraculous. Do you know, I mean, to take these things that in our society we battle against. I think there was an era when people thought it was a normal part of life, but we don't seemingly think that anymore, at least in the typical population. And to turn that into a spiritually moving, positive experience, that's a gift that you're giving people.
Yeah, and we're starting to collect some data along those lines that, for example, couples who go through that aren't getting divorced like the general population that receive those supportive services around that stressful time. Right. And similar, there's data showing that for those caring for a loved one at the end of life, that there's a higher mortality for the caregivers. And so we need to show data that we're changing that. It's important to change that.
Yeah, I think that we all agreed that data is important, but I'll bet with you here that it's going to go the right way. I think that you're going to show what you think you're going to show. I came across this line that I wanted you to comment on while I was preparing, and it said, rather than thinking of hospice and palliative care as a loss of hope, it was a redefining of what hope means. And I just thought that was kind of a really beautiful way to flip the image. Hospice is not the loss of hope. It's something else entirely.
Yeah, and there's a lot written about that, and that's one of the fears about coming to hospice for a patient, is that means I have to give up hope. And that's not true, because for one, it may not change your medical therapies. Again, it may just be an extra layer of care. But also, when things are changing, when it looks like life is limited, then our spiritual counselors, our social workers will help patients and families shift what they're hoping for. So it might have been, I'm hoping for my grandsons to see their graduation, their high school graduation. Well, they can shift that and say, I can hope to be there in a different way. I can write a letter, I can do a video that their grandchild will see when they graduate. So creating legacy and redefining hope, exactly as you described. It's a really important process for really the whole family.
You can't expect the average person to figure those things out without help. You just can't. I mean, I was listening to you going, what a great way to be at the graduation, make a video. Tommy, take a look at this. You know, Grandma wanted you to see this. You'll touch that person no matter what.
Yes.
But it's not, I mean, this is what a professional is for. In the short time we have left, I wanted to ask you about the future. And it occurs to me that you're training doctors, general doctors, medical students now to impact what they do in the future. You run a fellowship program in palliative medicine so that you have specialists like yourself. And I was going to ask you about the future, but I thought, he's doing the future already. I mean, you're already doing what you wanted to do to see the world change, but where would you like to see things be 10, 20, 30 years from now? How would you like to see it if you could make the world according to you?
Yeah, well, my pie in the sky is that healthcare in general will change, and that palliative care will really be seamlessly integrated into all healthcare systems, because it's doable, and it's really the right thing to do. It's what patients want, and it's what families want as well. And you mentioned our training program. We have currently we have 7 palliative medicine fellows, and
wow.
And we have between 7 and 12 fellows each year who are going to help us do this. And I think the viewers out there can do that as well by asking in their healthcare system, what do I have? Do I have access to palliative care? And can I help advocate for it if it's not there?
Well, that's where knowledge really comes into play, and that you came here and gave up your valuable time to talk about this, to make an impact, means that there are more people out there. This is your teaching component, and you do it extraordinarily well, that they know to ask for this. You mentioned one other thing that I want to give you one more chance to talk about, the free care that you give, because you don't turn anyone away. Mm-hmm. There are going to be people watching this who are moved and touched, or wish they had the opportunity or did have the opportunity. How can they help? How can they give?
Well, they can help by making a donation, and you can do that by calling San Diego Hospice or by using our website, www.sdhospice.org, to make a donation. And call us and see how, if you're interested in transforming healthcare and putting palliative care into existing healthcare systems, if you are in a position to help do that, call us. We'd love to work with you to do that.
I believe you. I mean, there's a genuineness and a passion that comes through that jumps out of you for what you do, and you were born for this. So thank you for all the work that you're doing. It's tremendous, and I've learned a lot, and I'm a physician in the community. So thank you for everybody who's had the benefit of what you're doing.
Thank you for having me. It's a pleasure being here.
My pleasure. You've just been listening to A Difference Maker. Dr. Buchholz has told you all about how you can transform the end-of-life experience. Knowledge is power, and we say that all the time here on Health Matters. This is one of those times where it really matters, and you need to think about supporting the people in our community who are transforming not only healthcare, but the spiritual matters of our lives. The mind-body health connection is crucial when we think about our healthcare, and you just heard someone, a real world's expert, tell you how we can make that difference. It is your responsibility to stay involved. It's our responsibility to do our job. This was a big one, and I hope you were listening carefully. I'm Dr. David Granite, and we'll see you again next time right here on Health
Out there right now is on the fence of whether or not they should accept hospice for their loved one. I think that they need to consider that hospice is well trained in the end-of-life process. They knew more about the end-of-life process than anyone, than the doctors or nurses or us, the caregivers. We were unable to help her in her end-of-life process without hospice.
I am very, very impressed by the job that hospice does to help not only patients in their time of need and in their last months of life, but also families. Hospice is, for patients, it's to help to control their pain, but also hospice is just about as important for the families of the patients as for the patients themselves.
When we're talking about our hospice family, I refer to them in that sense as we have a team of nurses, a physician, and clerical personnel who actually take a vested interest in the hospice patient.
Many times I see initial hesitation with families about deciding on hospice care for their loved ones, but in a few days I've always seen 100% acceptance and actually great appreciation for hospice care by the family members, because it is very good to see that your loved one is being cared for and is comfortable.
I think the main benefit actually for hospice is divided again equally between the family and the patient. We are experts at helping the patient maintain good pain control. We're experts at being able to have the patient tell us, you know, I want to be completely pain-free, and I don't really care how sedated I am. I really want to be totally pain-free. You know, we can do that, or the patient can say, you know, I'm willing to accept a little bit more pain to be more alert. Anything in that spectrum, really, we're very good at being able to manage that at home. And then in terms of the family, you know, just providing support. All the time I see situations where the social worker will go and obtain some benefit, something that had nothing to do with hospice. You know, something that was out there that they had this resource and they were able to bring that and help the family out with that resource. But just it's a multidisciplinary approach where many different disciplines are involved in trying to help the person.
When the hospice team is asked to come in and help an individual in this situation, there are many needs that can arise. Obviously, they need the medical care. They need the nursing, the physician care. They need the medical aspect. A lot of other needs also come about. There's things such as setters at times. They need aids. They need help with bathing. They need social services. They need religious guidance. So basically anything that a hospice patient needs or what the family needs, we're able to provide that for them.
Hospice offers a great service there, not only to provide comfort to the patient, which the family members greatly appreciate, but also they provide counseling and support for the family members.
We've been having a lot of new referrals and getting to meet a lot of new patients and families and get in there and help provide the care that they need to get them comfortable in the home setting so they can stay there for their final days. I make routine visits just to reassess anything that I have changed in these plan of care, such as pain. You know, I want to go back and make a visit to make sure that the pain medication that we have ordered is working effectively and that the patient is more comfortable and, you know, just able to do more for themselves and with their lives like they deserve.
That's what hospice is all about, is to provide comfort for the patient and for the family.
You know, as far as my own training, I'm a family physician, and as a family physician practicing for over 20 years, I've dealt with a lot of people in pain. I feel that we're really well trained to deal with families, as being a family physician, dealing with people that are going through the stages of death and dying, and especially when it comes to making the patient comfortable. I think that that's what we're primarily about. Our role in this instance is not to try to push the individual back into treatment. It's to try to listen to the patient and do what they want us to do, and I think that we have the training to be able to understand that and be able to communicate effectively both with the patient and their families.
When people are deciding to get hospice involved, it is our protocol that we send a team to their home and meet with the family and the individual. There's no obligation for this service, but it's an educational time where the family, the person involved, can meet with our team so they can see exactly what it is that hospice has to offer.
A lot of people think, well, hospice is only for patients with cancer. And even though a large number of patients who are on hospice do have a terminal cancer, there are a lot of other illnesses which would qualify for hospice. As a matter of fact, any chronic illness in which the physician thinks that there may be a good chance that the patient won't survive for more than 6 months could qualify for hospice. Things such as emphysema, severe heart disease, congestive heart failure, certain neurologic conditions. I've had patients, and I have patients now who are on hospice who have, for example, Lou Gehrig's disease. So you don't want to think of hospice as being only for cancer patients, and you don't want to think of hospice as being only for when the patient is in extreme condition.
Any type of chronic condition. I mean, if you think that the individual is in the final stages, and I define that as, at this point in time, there's really no more active treatment. There's not referrals being made to other physicians. The person isn't going back to the hospital repeatedly to try to get acute care. Those are the situations where the person should be referred. In terms of diseases, dementia or Alzheimer's disease, the referrals can come from actually from nursing homes in that regard. congestive heart failure, chronic lung disease, any form of cancer, renal failure.
When people think of hospice, obviously we think of end-stage cancer, terminal, untreatable diseases. That's not always the case. There's many other situations that will qualify you for hospice. Situations such as end-stage Alzheimer's disease, congestive heart failure, end-stage pulmonary problems, oftentimes that these people will qualify for hospice.
Hospice is initially initiated for a 6-month period, but after the 6-month period, the physician reevaluates the patient and hospice can be extended.
Many people have had their primary care physician, their family doctor for many years. They don't want to give them up. They're still free to see them and have them involved in their care. We also work with the primary care physician with hospice if they so desire, but by all means they still have the freedom to see their regular physicians and specialists.
The patient can continue to see their family doctor, and the hospice service actually works well with the patient's primary care physician and actually encourages the patient to continue the relationship with the primary care physician.
They have a family bond with these patients too, and they may not be able to provide one-on-one care like the hospice is, but they still want to know what's going on in that patient's life, in the care they are receiving.
It's not that we're just going to give up on them. That if there's something that happens to them, we're trying to fix that actually to the best of our ability. Now, the whole philosophy behind the hospice is for the person not to be going back and getting chemotherapy or getting being admitted for situations that could be dealt with at home. I think that people need to realize that we don't give up on them, we don't stop treating them, we don't stop giving them a lot of their regular medicines.
When people begin thinking of hospice, oftentimes they think it's a certain building or facility that they have to go to, and that's absolutely not the case. The hospice is a concept where we bring the entire team to the individual. Our objective is to keep people at home where they're in a comfortable surrounding and setting. So we bring the entire hospice team to your home environment, and that's where we provide our services.
Hospice services are provided where the patient feels most comfortable. So the patient can be at his or her home, in a nursing home, and sometimes even in the hospital, and can enroll in hospice, and hospice services will be provided at that location. Another great thing about hospice is that it's a service to provide comfort and care for the patient and the family, but the patient, if decides down the road to terminate hospice service at any time because they've changed their mind or there's a new treatment that is available for their current illness, the hospice has no problems if the patient terminates the service and tries another treatment. If the patient wants to go back to hospice after that, hospice also welcomes them with open arms.
The thing about hospice is that it's not a decision that is set in stone. You can revoke your hospice treatment, and that revocation or being revoked means that then you can go back to a more active treatment. So let's say something happens where there's a new drug, or something new happens where the individual wants to resume more active treatment for their disease, then they revoke their hospice treatment and they go back to the more active treatment. Similarly, if an individual finds that they feel uncomfortable with how the treatment is proceeding, in terms of some people get anxious being at home and thinking that they then might pass away in their home, and some of them want more of a hospital type care. Under those circumstances, they can completely come in and say, hey, I want to go back to the situation where I was getting more of an active treatment and more of the traditional medical care for their conditions.
The equipment that hospice brought to my mother-in-law's home was at no charge to us or my mother-in-law.
All medications that the patient takes, all medical supplies, including bedside facilities, etc., are covered by hospice, and the patient does not have to bear any cost whatsoever.
Most of the medicines are covered by Medicare. We run our prescriptions through Hospice Pharmacy, which is a specialist pharmacy that deals primarily with patients that are under hospice care. We also use regular pharmacies in the area as well, but the medicines in most cases are totally covered by Medicare and or the prescription drug program that the person has.
When we reach the situation where hospice is needed, there are no more medical costs for the individual or the family.
I would encourage you to think about it early on and get those services, which are, by the way, totally paid for through Medicare and through private insurances.
We didn't have to do anything. The hospital made all the calls to hospice. Hospice showed up at the house with things that we didn't even know that we needed. The hospital bed, you know, potty chair, oxygen. They brought everything to us that we needed and to care for her.
The problem that I see more often is that people get into hospice too late rather than too early. And I would encourage families to be thinking about hospice services if they have a loved one who has a chronic illness.
Some people, when you go to admit them, they're kind of wary about hospice, and then after the nurses come in and make a few visits, you know, then they just open up. And they're so thankful for us being there, and they see what a big difference hospice has made.
When we talk about referrals to hospice, unfortunately, these referrals, I feel like, are not made soon enough.
We should try to initiate hospice services sooner rather than later, because the longer the patient is comfortable, the better it is for the patient and for the family.
They helped us to understand what to expect in the end-of-life process.
I think it's important once a terminal disease diagnosis has been given that very quickly we get the entire hospice team involved. Again, what we can bring to the individual and the families is to educate them. You know, what's the problem? What can we expect? They need to know what hospice can do to help them out, not only medically, but also the emotional aspect, the anxieties, depressions, the angers, the social aspect, religious needs. And the sooner that we can become involved with this, the easier it's going to be to help them through their situation.
It could have saved our loved one a great deal of suffering and pain, as well as eased our minds in the sense that we would have known more of what to expect and been more comfortable with caring for our loved one.
When a patient gets a terminal diagnosis from their physician, this is a team problem, a team effort. Not only is the individual involved, but the family's involved. And so it's very important that the hospice team is able to come on board, educate them, you know, what is the problem, what's their disease, what do they expect as time goes on. And the more people are aware of what the issues are and what to expect, then the easier it is to help them through these difficult times. And that's what hospice is able to do, is provide the education, bring this service to you, and help people through these difficult times.
If we could get some of these patients on sooner than what we do, I really do believe that even though hospice goal is not to prolong life, that we definitely make their quality of life better, which in turn causes them to live longer than probably what was expected, because we just help get their pain and symptoms under control. We manage that well.
Had I known then what I know now, we would have had hospice much sooner. Hospice is a family's decision to care for their loved one with compassion, love, and hospice offers all the tools necessary in doing such.
One of the biggest concerns that we consistently run into is pain and suffering. I mean, you know, everybody is just petrified of as they get to this situation, are they going to suffer? And I think it's something extremely important that the hospice has to offer, is that we can bring this service to you. We can minimize your pain and suffering and keep you comfortable in your home setting.
One of the things that I think we should realize about hospice is that hospice is not a building, hospice is not a place. Hospice is a concept, and hospice is a group of providers, nurses, social workers, physicians, who help families to care for loved ones when they are in their last stages of life, in the last stages of dying. And the hospice concept is a fantastic concept which I have used for over 25 years and have had many, many patients who have really benefited from hospice services. And I would encourage families to think about hospice early on in the disease course rather than later.
I just can't express the amount of care that this team of medical and paramedical people provide for the hospice patient. I think in the latter days and weeks of life, that's an extremely important aspect of one's care. And for that reason, that's why I would highly recommend hospice under those circumstances.
I'm always just so impressed with the kindness and dedication of the people that work for Tri-County Hospice.
The angels of hospice, I call them, because they are angels. Anyone who works for hospice has to be, because she came and she was so tender and caring and loving with my mother-in-law, just the same that I was.
I think what a patient and family can expect by choosing Tri-County Hospice is a loving, caring, compassionate relationship that just grows over the time spent in the home. We care and love these patients just like they were our own family, and provide the best care and treatments available to help make them comfortable as they're going through this trying time. That's never easy, but hopefully with hospice in there, it does make it easier for the family and the patient.